Yes.
How long has it been that the attending physician determines the status? Has that been for several years? Because,
Why?
well, because our attending physician said he had nothing to do with the status or whether you were an inpatient or outpatient. That's what they told me every day for 4 days. So I thought maybe this is something new that we can go
No,
to the physician.
this isn't anything new. It's that physician just
Pass the buck.
didn't understand. Yeah, didn't quite understand.
Is the attending physician, could it be an emergency room doctor?
Quite often, what happens with the emergency room, and that's a good question, and I don't want to stray too much, but you've got emergency room physicians, right? None of which have admitting privileges to a hospital. So they work in the ER to do ER medicine. So if you come in the ER and you need to be admitted, they have to get an attending physician with admitting privileges to admit you to the hospital. So what happens is the ER doc sees you and says, oh, hey, do you have a regular doctor? Yes. They'll who's on call for your regular doctor? If you do, if not, there's a hospitalist. They pick up the phone and say, look, I got a patient here that's having chest pains. We want to admit him. Had a heart attack. Yes, they get an attending to admit you. But the attending makes the call, not the ER doc. Because he or she has no privileges to admit.
But when you're saying that, you're using admit to mean inpatient or to admit to mean
Take care of you in the hospital, period. To take care of you after the ER, attending. So you got an attending. You'll never see the ER doc again once you go past the ER and up to the floor. They don't come up and visit you. They're just doing ER medicine. That's it. Yeah.
If your primary physician says, I want to admit you to the hospital, then are you inpatient or are you outpatient or don't we know yet?
We've got we know pretty well because we've got a real good process here at NCH where if your physician wants to direct admit you, that has to come through our bed board and our case management department so we can look to see is it in, is it out, what is it?
But at midnight that's not going to happen.
Midnight that's not going to happen, so we don't get a lot of direct admissions at midnight. Typically it comes through the ER, but if it did, we would have to review that case the next day. Yeah.
But I think it's important to say that there are criteria that the admitting doc has to use. It's not a sort of willful, oh yes, you're inpatient and you're not.
Right.
You have to meet certain criteria.
Right. Keep in mind, it's your medical condition. Okay? I'm kind of sick at my stomach and I've got a urinary tract infection. Where do most urinary tract you got a urinary tract infection, typically you go to the doctor and you get your Scepter, your Cipro, and you go home. If you come to the ER with a urinary tract infection, you don't need to be upstairs. Medicare does not think you need to be, they're not going to pay several $1,000s for you to go be an inpatient on the 4th floor because you have a UTI. That's a medical condition that typically is treated by your doctor in the doctor's office. Do you understand that they can pay that doctor's office $120? They don't want to pay NCH $3,000 because you have a UTI. You see, that's the basics there.
So it's the system and the doctor working hand in hand.
It's what your insurance is going to cover and based on your medical condition. That's it. If you have a heart attack, you can't get that taken care of in the doctor's office. He's going to ship you to the hospital because you need lots of monitoring, lots of medication, lots of stuff. Medicare, yes, we don't want Dr. Joe in his office treating you for a heart attack. We need to take that to the hospital. Same thing with certain procedures. Medicare has, who's heard of an inpatient-only list? Every year, Medicare puts out, just like they put out your Part B co-payments and stuff that keep going up, right? They put out the same list of certain procedures that have to be done in a hospital. That's for safety. They say if you're getting anything done with your carotid arteries, you're just getting them cleaned out. Some of you guys may have had that. Get them cleaned out. That has to be in a hospital. That we don't want anybody out here on Tamiami in a shop doing this. We want them in a hospital where they can be monitored and if something happens, taken care of. It's a very specific list of procedures. Has to be done for your safety in the hospital. So there's a list.
With
Yeah.
admitting diagnosis from a UTI, if they're septic, could that be considered
Sure.
an admitting diagnosis as inpatient?
Yep. All right.
Okay.
Yes.
So your attending physician essentially is your doctor.
He's your doctor when you're in the hospital, and we have
No, wait. Say I have a private doctor that I go to routinely.
right.
Okay, is that the attending physician or not?
Only if he has privileges and comes and treats you in the hospital. And we have a few that do that. We still have a few that do that. Typically, you will not see that. Typically, what you'll have is your doctor that you go and see, primary doctor, your PCP here, and then when you come in, you get a hospitalist. Somebody to take care of you.
Hospital doctor.
You got a hospital doctor, right, that just does hospital medicine. Most of your primary doctors just cannot see patients all day long and then see patients in the hospital. I mean, they just physically have trouble doing it.
So when you go to the emergency room and they decide that you need to go to the hospital assigns you a doctor.
Sorry. But there's a lot of physicians that we have. You have, if there's a lot of physicians in the community that they work together. So we have a group, several groups, that they may have the practice out here seeing you as a primary, and one of their partners would see you in the hospital, but they just don't do both. So he does out here in primary, and he works in the hospital. So we've got a combination of doctors. Think about doctors. Think about the hospital where physicians can practice. Okay, that's practice. So we've got a good group, good mix here. All right. Any other questions on this? All right. Can your status change during anybody had that happen to them? Yeah, status can change based on your medical condition and treatment. And I'll give you the most classic example. It's the easiest to understand, but it applies for everything. Is chest pain. So a patient comes into the ER, has chest pain. Now we all know chest pain can be muscle. It can be GI. You can have a lot of indigestion. It can be a lot of things with chest pain. So what do they got to do? Typically, they're going to you're going to come in as an outpatient, okay? We'll talk about the observation piece in a minute. And they're going to do some testing. So they do the basic things to find out if you're actually having a heart attack. What's going to kill you if you walk through the door with chest pain? They'll run troponins. They'll hook you up to the EKG. If necessary, they'll do a stress test, right, to figure it out. After they run that lab work, there's specific lab work that's specific to the heart muscle. They're called troponins. So if those troponin levels are elevated, that's only in the heart muscle. It's nowhere else in your body. So they run those lab tests, and it takes 3 of them. So if those levels are going up, they go, you've had a heart attack. Maybe really bad, may not be so bad. Okay, you can have a heart attack and you might have some pressure, kill some parts of your heart, you'll never even know it. If it doesn't knock you down, you may not know it. But it's still a serious condition. They find out you have a heart attack, guess what Medicare says? Heart attack? It's an inpatient. You would go from your outpatient, after they ran your test, to an inpatient. Now here's the key. You have to be notified in writing. Okay? Now there's a couple ways we do that here at NCH. If you're an outpatient, you're typically going to get what you have here in your copy, but it's this little brochure. And somebody comes into you and says, oh, hey, you're an outpatient, your observation, because it's a requirement of Medicare for us to make sure you understand what your status is. Right? Because it's going to make a difference on how you pay, and you need to be informed on what you're getting. We do it like this. Registration, if you're an inpatient, you usually get what's called a notification of inpatient. It's called an IMM letter. So they'll ask you to sign it. Before you leave, they'll ask you to sign the same form again. You've had that happen, huh? That's Medicare's way of making sure that you know you're an inpatient, and when you get ready to leave, you know where you're going. You may be going to rehabilitation. You may be going home. You may be going somewhere. But that's a way for Medicare, for us to make sure that we're looking after you going, hey, you're getting ready to go to rehab. That's all, everything's good. If it's not, let's talk about it and find out what the problems are and how we can fix it. So it's your rights we're looking for. Yeah.
I'm sure that situations arise where your physician wants you to be an inpatient. And the hospital says, well, gee, I don't think that case will apply that one.
Happens day to day to day to day to day. It happens all the time. Happens all the time.
Who wins?
Well, your attending physician wins when it's all said and done. When it's all said and done, your attending physician makes the decision. Okay?
Being hospitalist or personal physician?
No, you're attending the doctor in the hospital, taking care
Doctor in
of
the hospital.
taking care
The
of it.
hospitalist is paid by the hospital.
Some are just practice there.
Contracted.
Well, yeah, they'll come to work there, but Medicare's paying them like they're paying the hospital.
What if your doctor is an admitting physician for that hospital? Can he override the hospitalist?
If he's taking care of you, yeah, he's got to be taking care of you.
Yeah, he's
Yeah.
attending to
Yeah, yeah. And there's a specific review process. So Medicare said you have to have a review process. Okay, so we've got. It's called a UR committee, but we don't. It's not. We sit down once every 2 months, but it's a workable committee. So there's 2 independent docs that work on that committee for us here. Some may only have, 1 at a time. We've got 2 active ones that work for us. So if there's a case where the attendings don't agree, and you'll have this happen every once in a while, so we'll even have one of the UR docs and the attending not agree and have to ask the second UR doc to kind of solve it. All designed to make sure you're getting the right level of care. By Medicare.
They only meet every 2 months.
No. The committee just sets down, but day to day, like while we're talking right now, there's 4 or 5 reviews going on just right down here at this hospital. It's constant. It's a constant fluid system. Mm-hmm. Yeah.
How long does it take once they have determined your status and your status of change? How long does it take for them to notify the patient or the patient's advocate?
It goes pretty quick in most cases. So has anybody had that happen to them in here? Okay, when did you get notified?
4 days.
4 days into your hospitalization?
4 days, yeah, 4 days in a bed on the 6th floor and not knowing whether you're an inpatient or outpatient.
How long ago was this? I'm just
That was a year ago, May.
Okay. Okay. It's pretty fast, and I'll tell you why. The guidelines for Medicare are pretty clear. So if you don't get things done in a timely manner and you don't appropriately notify, then by Medicare guidelines, you cannot bill that claim. You just can't even bill for it. So you gotta kind of Medicare. I know all the issues that we see with Medicare. Most of everything that they put out, as far as the inpatient hospital side goes, it's all about protecting you and your rights, and it's work. It's a lot of work. Yeah.
Quick question. For example, I take care of my mother. She's in the hospital for a week.
Right.
I've never gotten a letter saying that my mother's status is such and such, which is one of the reasons I'm here, to learn what all this is about. So does that mean that she's never been actually inpatient, although she's been in the hospital 5 to 7 days?
If you go back and look at some of the paperwork you probably signed when you first got admitted through registration, when they came up and said here and sign here and do this and those and read
Is it a
this.
separate letter, or is it like small print somewhere?
No, it's in there. That
Yeah.
letter's in. Yeah, that letter's in there. Now this will come to you like this sometimes. This is a really good, this is straight, the one you have here is straight out of CMS. They update it every year. It's got some really good information in it. I encourage my folks to give both. So if you're in the hospital a year ago, you may not have gotten both. But I encourage my guys, I've been down here since February, so I encourage them to give both. So it's really good. There's a lot of 1-800 numbers in there. There's a lot of information, website information that you can get. Because you need to know your rights, its requirements. So check the stuff you're signing when you sign in. You're probably getting your inpatient right there. That's how it's designed to go. So you're being admitted. You're going to be as an inpatient. sign here, sign for your mother. You'll see your IMM letter right there. I wish I would have brought one to show you. But you're signing in. Yeah.